Our next topic for discussion is common back, hip, and foot issues. It's going to be presented by Dr. Meyer, Josh Meyer. He is a pediatric surgeon, orthopedic surgeon at Norton's Children's Hospital, Orthopedics of Louisville. He earned his medical degree from the Medical College of Wisconsin in Milwaukee, then completed a general orthopedic surgery residency at Henry Ford Hospital in Detroit. Dr. Meyer completed a fellowship in pediatric orthopedic surgery and scoliosis at the Texas Scottish Rite Hospital from Children's in Dallas. He also serves as a staff physician for the Kentucky Commission for Children with Special Health Care Needs. Welcome, Dr. Meyer.
Thank you. Share our screen here. And let's get this. Trying to just get it into presentation mode here. There we go. All right. Well, thank you very much for the invitation today. I really appreciate it. And so we're going to talk a little bit today on some common back, hip, and foot issues. We'll try and hit some common ones that we see, and it will be a little bit of a lot of little things, but I think we can hopefully get some knowledge out of this. So I don't have any relevant disclosures to this presentation. So today we're just going to discuss those issues and maybe understand some common treatment options for these conditions that we offer here with the Children's Orthopedics Department. So we're not going to talk too much about zebras today. We're going to talk about common things. So with regards to the back, one of the most common things that we see is back pain. We'll talk a little bit also about scoliosis and spondylolisthesis, which is something relatively common to us, even though it's maybe not as well known. So childhood back pain is really very common. We typically see it in adolescent patients, those over the age of 10 typically. It is pretty rare for a young children, say a 3-year-old, a 6-year-old, to have much back pain. If that's the case, we definitely look into that a little bit further, as that can be much more indicative of a structural issue. But about 1/3 of adolescent patients have back pain at some point in their adolescence where they voice a concern or see a provider for that. It is very rarely structural pain. In other words, kids don't get, say, disc problems, nerve pinch, those kinds of things that are typical back pain in adults, causes for back pain in adults. Usually it's an insidious onset. So a lot of times adolescents will have, a number of months of some mild to moderate pain. And like many teenagers, those of you who have teenagers especially, you kind of understand that they are not real forthcoming with a lot of their complaints usually. They're typically kind of keep to themselves a lot maybe. And so they might not mention it for a while until it gets to a point that it's bad enough that they voice their concerns with regards to back pain. Occasionally it can be an acute injury. So sometimes in a football game or in a wrestling match or something like that, where you have an acute injury to your back that can cause some back pain. So like I said before, the majority is non-structural. So most of us who treat these kids, it's common for even like parents and maybe other non-medical people to kind of know a little bit about, say, a slipped disc or a pinched nerve or some spine arthritis because maybe they've experienced that themselves. But in kids, this really is pretty rare. You can see occasional disc herniations or things in teenagers, but honestly, the most common cause is just simply muscular pain of really relatively uncertain etiology. Exactly what the pain generators are, sometimes it's hard to say, but the majority by far is just muscular pain. Other causes that we want to be kind of aware of and look into, one of those would be tethered spinal cord. So this is something that is common enough that we kind of screen for it when we see patients with back pain. That typical triad would be toe walking, low back pain, and constipation. Now, obviously, there can be other things such as generalized leg pain or weakness or tightness, urinary control difficulties, those kinds of things. Typically, we will order an MRI on those kids if they have those symptoms or some physical exam findings that suggest maybe some abnormal reflexes, for example. We will order an MRI of their lumbar spine to evaluate for that. And a neurosurgeon can release that if they feel that that is the cause of their symptoms. Another somewhat common cause would be a stress fracture. And we'll talk about this a little bit more as we go along. That is what essentially a spondylolysis is a stress fracture. And so we will kind of evaluate for that. So typically we will do some initial radiographs, especially again in the setting of trauma. If there's an acute injury or a known injury, definitely x-rays will be very helpful to us to evaluate for that. A spine fracture, a true spine fracture, again, is relatively uncommon in a child who, say, has had simply a sports injury or something like that. That would be more of a major trauma, major fall, car accident, those kinds of things. Generally, if x-rays are normal and their exam is typically benign, which it usually is as far as no structural issues, weakness, those kinds of things, we will recommend what we call home treatments. And that would be your typical things: ice, heat, massage, yoga, sports creams. I tell a lot of my patients now that they can go on YouTube and search, yoga back pain. And if their parents allow them on YouTube, they can go on and find all kinds of free 15, 20, 30-minute videos on yoga exercises for back pain. And I think those can be very beneficial. Oftentimes, if they've maybe tried some of those things, and if they come in and say, boy, I've tried all of that stuff, it's really not helping me, I've had pain for a number of months, then we will recommend some physical therapy. With normal x-rays and an otherwise normal exam, it's really rare that physical therapy could harm anybody. And so we will definitely use physical therapy quite often with regards to back pain in adolescents. And they're old enough to understand the exercises, to do the treatments at home, and they can usually have quite good success with physical therapy. So we'll move on to scoliosis. So this is not something that's a common cause of back pain. And it's sometimes hard to maybe understand that. You look at an x-ray and somebody that's got quite a large curve, and you might think, holy cow, how can they not have back pain? And honestly, the large majority of patients with scoliosis, even if it's a larger scoliosis, is relatively painless. And so people have looked at studies that would suggest about a third of patients with scoliosis will have some type of back pain, and about a third of teenagers in general have back pain. So essentially, those of us in our field tend to think of scoliosis as not necessarily a pain-generating problem. So scoliosis, again, is a lateral curvature of the spine. There's really no known etiology behind it. There are definitely some ideas, some thoughts. It is likely a combination of some genetic markers, some possible endocrine factors, and like many pathologies or disease states, if you have, say, A, B, and C check marks, you likely will develop that. Whereas if you don't have maybe that constellation of issues, then you will not develop scoliosis. So it's still somewhat difficult to understand the true reasoning or cause behind it. There is no cure for this. Since we don't understand the actual cause of scoliosis, there's nothing we can do to cure it or to make it go away. We can simply treat the problem. So one of the things on exam to remember is that it's a three-dimensional deformity. So when we do what's called the Adams forward bend test, as you can see here, it's you trying to evaluate for the rotational prominence of the ribs, and that's shown in this little drawing of how the spine doesn't only curve, but it actually twists. And so you see some rotation at the apex of the curvature, and on the lateral view of the x-ray or the side view of the patient, you actually see a loss of the normal kyphosis. So their back is actually much flatter when viewed from the side than a typical spine would be. So treatments for scoliosis essentially are observation, bracing and therapy, and surgery. So observation is indicated in smaller curves and or curves in patients that are skeletally mature. So this is an example of a 15-year-old girl onto age 17, and over 2 years her curve is essentially the same. She's done growing, she's essentially skeletally mature, and so it is unlikely for even a moderate curve of 30-some degrees to progress into adulthood once you are skeletally mature. And so this kind of curve like this, she could live with, and usually I'll counsel my patients and parents, a child like this could live with a curvature like this for 70, 80, 100 years and likely not have any issues because of it. With her spine or any of the internal organs. Bracing is indicated in curves that are typically 25 degrees or more, and in kids that have a lot of active growth remaining. So this child here on the left is around the age of 10 years old. She still has quite a bit of growth remaining. Her curve has progressed from that first x-ray on the left to the second x-ray from 17 degrees to 28 degrees, and that would definitely be an indication for bracing, as she still has a large amount of growth left. She's still kind of in that pre-adolescent, what we call peak height velocity phase, and that's when curves want to get worse. And so that's definitely a patient to initiate a referral on. Typically, when we do bracing, there's multiple brace types and styles. We'll talk about a full-time brace being about 16 to 18 hours a day. The previous recommendations of up to 23 hours a day are likely not really, that extra time likely does not have a true difference-making ability. And so 16 to 18 hours a day is typically what we'll recommend. Occasionally, a curve in the lumbar spine can be treated with a nighttime bending brace, we call it, as those curves are oftentimes more flexible and can respond to that type of brace, which is oftentimes more commonly, it was better tolerated. And so these are examples of the different types of braces that are available. We have some, luckily enough, some orthotic companies in town that are really good with making our braces and can even do things like 3D body mapping and things like that to actually make the brace a custom fit for a patient. SCHROTH physical therapy is definitely worth mentioning. This is not general physical therapy like you would do for, say, a shoulder or a knee pain type of thing. This is a German method that was designed to decrease or actually cure the scoliosis. And whether or not that's actually true, it does seem to show some good results with treating especially the mild to moderate curvatures before we get to surgery. So it is basically a combination of breathing exercises, posture training, selective strengthening. There is a little bit of equipment that's necessary, and it's typically an adjunct to brace treatment. And so we have two excellent SCHROTH physical therapists that work with the Norton system at the Neurospine Institute downtown, and they have been an excellent resource for our patients. Now, SCHROTH therapy is fairly time intensive. It's weekly visits for a number of weeks, usually a month or so at least, and then daily home exercises. And so it is somewhat of a intense therapy program, and it's not for everybody. We see lots of patients that come from 2 or 3 hours away that SCHROTH therapy is really not something that's feasible for them, but we certainly offer it to anybody that is interested as an adjunct to our treatment. Surgery is reserved for patients who have larger curves, we'll say over 50 degrees or more. And the reason is because those curves have been shown in long-term studies to continue to progress throughout adulthood. And so we use a spinal fusion surgery to stop the curve progression. And that's to improve the alignment as well as decrease the rotation. But what we see is that the goals of surgery, and this is what I would tell patients, is to stop the curve. The goal is not to make the x-ray look better or to straighten the spine. The goal is to stop the curvature. There usually, very oftentimes, is some residual curvature. As the spine has been curving for a number of years, you can't simply straighten it in a number of hours. But it does improve alignment and decrease the rotation. Now, in kids maybe that are a little bit young, that still have more growth remaining, we will use different types of therapies such as growing rods, magnetically controlled growing rods, tethers, some new technologies that are designed to not fuse the spine, but to allow continued growth. And those are rapidly evolving as we go along. And then to finish up our back portion, a spondylolysis. This is a defect or a fracture in the area that's called the pars interarticularis, as you can see in this drawing here, this little red line. And it's basically in between the joints of the spine. And there's a number of different reasons for it. It can be congenital, it can be a traumatic injury, stress-induced, and it's usually caused by hyperextension, so continuing repetitive extending at the lumbar spine. And so that's like linemen in football, gymnasts, divers, dancers, anybody who does a lot of, say, back bending or hyperextending. This can be sometimes a common finding or something that you at least need to be aware of to look for. Typically, x-rays don't do a great job of showing it. You can sometimes see it on x-ray, but it's more commonly seen on an MRI or a CT scan. And so you can see on the CT scan on the left image there, right where it says letter A, there is a small crack or a small defect in that area, and that's what we're looking for. These often can be asymptomatic, or they can be made to be asymptomatic with treatments. And so it's really almost always a non-operative problem. Very rarely surgery is necessary to repair this. So we typically treat it by activity limitations to avoid hyperextension. There may be a role for brace treatment. It's a little controversial, but an anti-extension brace can be utilized to try and decrease their symptoms. Physical therapy is very important to regain hamstring flexibility and to have the muscles around that area be able to protect it. Time is really one of the most basic issues with it. It's sometimes it can be 6 to 12 months for full resolution of symptoms. So that's some quick back things. Now we'll move on to hip problems. I figured I'd focus on 3 hip problems here: septic arthritis and synovitis, which is something that a lot of you in primary care definitely deal with. A little bit on PERTHES disease and slip capital femoral epiphysis. So a septic hip or septic arthritis is a bacterial seeding of the hip joint. You can see on these x-rays kind of some of the sequelae of untreated hip infection. Antibiotics have a lot of trouble penetrating the joint capsule, and so to get into a hip joint or a knee joint is very difficult, and so that's why sometimes an orthopedic surgeon is needed. This again can lead to rapid destruction of the joint cartilage and requires surgical drainage oftentimes to treat. As opposed to a synovitis, which is really just a joint inflammation, it can be preceded by a viral illness or some increased activity, but not always. It is a self-limiting benign condition, which is very different from an infection, which gets worse and worse until somebody treats it. The treatment for a synovitis is rest and anti-inflammatories. The reason these are difficult to sort out is because they both typically present the same way. They present with pain, fevers, inability to bear weight, an irritable joint on exam. So here's just a picture of a child that's holding that left hip and leg into an externally rotated flex position. And the reason they do that is because it decreases the pressure on the hip joint to decrease their pain. So in order to help sort this out, we do a variety of lab tests. So a white blood cell count, a SED rate, and a CRP really help us to determine this. Typically in septic arthritis, the values will be higher. So you oftentimes will have an elevated SED rate and CRP in a synovitis. Usually in a septic arthritis, they tend to be a little bit higher even than in synovitis. The KOCHER criteria was, Min KOCHER is a pediatric orthopedist in Boston who came up, wrote a paper on trying to look at some predictive factors of septic arthritis versus synovitis, and came up with four criteria basically, and those are listed there: a fever of 100.3, white blood cell count greater than 12,000, an ESR of greater than 40, and inability to bear weight. People have used these and gone forward even adding CRP of greater than 1.5 as maybe a 5th predictive sign. So imaging, we pretty much get an MRI on any rule out infection, especially around the hip, because there are things you can miss if you don't do an MRI. So for example, if you have osteomyelitis, a subperiosteal abscess, those are things that by doing even a drainage of the hip joint, you could certainly miss an infection somewhere else without having the advanced imaging. So the advanced imaging with the MRI really is a crucial part of the diagnosis, because even taking a child to the operating room to put a needle in their hip joint, that's not a benign procedure. And so I really want to have as much proof and evidence as possible before I'll take a child to the operating room for a presumed septic joint. So the treatment again is surgical drainage. So we typically will do the joint aspiration in the operating room because the hip joint is a joint that's a little more difficult to accurately aspirate as opposed to a knee. That's really quite easy to do, say in the emergency room. If it has a high cell count or looks cloudy, we will proceed with an operative drainage of the hip joint. And typically this takes 2 to 6 weeks of antibiotics, and we let our infectious disease colleagues are very helpful in telling us how long to treat the patient based on the organism. Again, the treatment for transient synovitis is more rest, anti-inflammatories, and spontaneous resolution could be expected. So on to Perthes disease. Perthes disease is again named after one of the physicians who originally described it a little over 100 years ago. And it's a loss of blood supply to the immature femoral head. So it's essentially avascular necrosis of the femoral head. The difference between childhood Perthes and adult avascular necrosis really is the fact that kids have the ability to heal and remodel and restore blood flow. So there, again, as many things in pediatric orthopedics, there's no known cause. There's a bunch of theories out there, and it's likely a combination of those listed. Again, it causes bone loss and collapse of the femoral head as we go along. This is most often seen in boys age 4 to 10. That's the classic presentation. It usually presents as a limping child. Typically, there's no known injury. Most parents who have a child who limps, they're trying to remember an injury or recall an incident that happened. Usually it's kind of just, no, they just started limping about a week or 2 ago and we're not sure why. Can often lead to referred thigh and knee pain. The brain interprets the hip pain as more of a knee pain. So here's some MRI findings of Perthes disease. So you can see on these how you can see a normal femoral head on the image on your left. The normal femoral head is on the left side of the screen, whereas the white little arrows there are pointing to the flattening and collapse of the femoral head. And you can see the difference there of what a normal hip joint and an abnormal hip due to Perthes looks like. So treatments for Perthes are extremely varied and extremely controversial, and most people in our field really dislike Perthes disease because it can lead to some really bad outcomes in kids, and there really is no treatment consensus. So like most disease processes, if there's multiple ways to treat it, there's not one good way to treat it. So we typically will observe and do some activity modifications. Physical therapy can help to increase the hip range of motion. Occasionally, muscle releases or bony surgery are needed to help contain the head and the acetabulum. But honestly, surgical treatment for Perthes is somewhat uncommon because you can't reverse the process of the blood supply going away. The child will reverse that process on their own. It's simply a matter of what kind of shape does the femoral head come back with when the blood supply reestablishes itself. And that's typically over, say, a period of 1.5 to 2 years from discovery of Perthes disease to, say, resolution and remodeling. So again, here's some examples of some surgical procedures. On the left is after some soft tissue releases and what's called a Petri cast. So those are 2 long leg casts with a bar. That is really not a wonderful, convenient treatment for families and kids, but it is helpful to kind of reposition the hip within the acetabulum. And you can see on the right x-ray some bony surgery to, again, place the femoral head deeper into the acetabulum. The prognosis really depends on the severity. An older child is going to do likely somewhat worse. A younger child with less collapse will likely do better. They have more remodeling potential. And more severe disease, if you have bad Perthes disease, that can often cause you some severe degenerative arthritis in your 30s and 40s. And so a total hip replacement for kids, for adults that have had this is not uncommon, younger than you would really like, to be honest. And then slip capital femoral epiphysis. This is something that in the emergency room or primary care should really be aware of. It's a slip of the femoral head through the growth plate. And it's typically in a slightly older age group. 10 to 14 would be typical. It's very rare in younger kids. So 6-year-olds do not get a slip capital femoral epiphysis. And it is not found in children who are done growing, a skeletally mature patient. This is an example of what that looks like. The hip on it's the right hip, which is your left side of their screen, is normal in appearance. And you can see the difference of the patient's left hip or the hip on the right side of your screen, that the growth plate is widened and the anatomy has changed. This again can present as knee or thigh pain. It's often referred from the hip, so be aware when I was training as a resident on our peds rotation, if you went in to see a patient that had knee pain and you came out of the room and did not have an answer to what their hip exam was like, you went right back in the room and examined their hip, because that could be very tricky to kind of sort out. It's typically accompanied or found limp accompanied by out-towing, because the internal rotation of the hip is affected due to that anatomy. So that's the main exam finding, is pain and or limited internal rotation of the hip. Treatment is urgent screw stabilization, so it's not an emergency, but it's typically done, say, within the next day or two after discovery. This locks the head onto the proximal femur and prevents further slip, and ideally would cause that growth plate to fuse and heal. And that growth plate in the hip really only contributes 2 to 3 millimeters of overall length of the leg over time. So a major leg length difference is rarely, if ever, seen after treatment of a slip. So here's an example of a slip and the screw fixation, and goes on to healing. And finally, we'll finish up with foot disorders. We have about 4 or 5 minutes here. So a couple of things we'll go through just quickly: Sever's, clubfoot, flatfoot, and tarsal coalition, which sometimes can go together. So Sever's syndrome, or Sever's disease, is found in active kids 6 to 12 years old. It's simply growth-related heel pain. Again, there's usually not an acute injury. Oftentimes patients will say, oh, I think I fell, I hurt myself, but it's typically more of a gradual onset of pain. The nice thing about heel pain in kids is that it almost can't be anything else. So when I see a child with heel pain of this age group, we will of course do a thorough evaluation, get some x-rays, but it almost can't be anything else. Bone cyst or a stress fracture will certainly show up on the x-ray. If it's really not those, which are really some of the only other things that can happen, you're left with Sever's disease or syndrome. And kids don't get Achilles tendonitis. You know, an 8-year-old doesn't get tendonitis. Now, a 16-year-old could, but their growth plates are closed. So that's kind of the difference. Treatment is completely non-operative: rest, ice, soft heel cups, anti-inflammatories. I put a picture of something that I like to recommend to the athletes, where you take some Dixie cups and fill them with water and freeze them. And then you can do some ice massage by rubbing that ice cube or a couple of those. You tear the paper off as you go along, and that can be a nice adjunct to the treatment. And it's simply a matter of how much pain they can deal with. This does not lead to long-term issues with their foot or their heel. So rarely we put them in a boot or a cast for refractory pain, and that's pretty uncommon. So to touch on clubfoot a little bit, clubfoot is a much more serious condition. The incidence is about 1 in 1,000 live births, and this can lead to significant functional issues if it's left untreated. You can imagine those feet in a child who's fully grown would be significantly bad. And I'll tell you, sometimes when you go on mission trips and things, untreated clubfoot is oftentimes something that we typically see in other countries that simply don't have quite the access that we have to healthcare. So clubfoot is very difficult to correct with your hand. Sometimes newborns can come out with a foot that's turned in, and you can easily passively correct it with your hand to a completely normal position. That's not a clubfoot. Usually the clubfoot will be kind of pointed down, which is equinus, and then varus, which is turned inward. And so those are the clues that you have, and it's typically a somewhat of a rigid deformity. It's very rarely associated with other systemic problems. So what we do is we do PONSETI casting, and Dr. Jed Moyer, who's with our group, who's one of our non-operative orthopedic practitioners, he is an expert in PONSETI casting, and so he runs the clubfoot clinic here, and it's weekly casting with plaster casts covered by fiberglass to correct the deformity. And you can see the progression of treatment here as you go weekly to try and correct the deformity slowly through basically stretching casts. And that has really taken over for the aggressive surgeries that were done typically 15, 20 years ago, and have much better results than surgery. So again, it's weekly casting for about 4 to 6 weeks. You do an Achilles tendon release at the end of casting, and you wear a foot abduction orthosis for 3 months full time, and that's shown in the picture there. There's a few different designs, but essentially shoes with a bar that help keep the feet in an externally rotated position. And then typically, Dr. Ponsetti recommended up to age 4 years old, nighttime wear. And if you can get the child to wear that brace till they're 3 or 4 years old, their risk of recurrence is actually quite low. We'll finish up with flat foot and coalition. So flat foot is very common in kids. It rarely leads to long-term foot problems. It is different than a pathologic flat foot in an adult, which is usually due to a tendon dysfunction. The main things we'll assess if we see kids with flat feet is it flexible or rigid? And most kids' flat foot is very flexible, meaning they go up on their toes, the arch comes back, they have good side-to-side and ankle foot motion. And so those are the ways we kind of assess that. We'll look at their gait, we'll look at their ankle and subtalar motion. Most kids with flat foot, especially younger kids, don't have pain. Occasionally, sometimes a teenager may have some discomfort or pain. And we'll also look at their limb alignment. So we typically will recommend just a soft arch support or an over-the-counter insert. Custom orthotics are very rarely necessary. A rigid flat foot is much less common and obviously can lead to more pain and disability because of the fact that the foot doesn't move as well. So a CT scan or an MRI can often gain further information on their anatomy. So a tarsal coalition is something that can cause a painful flat foot. And that's a spastic or rigid flat foot because it's abnormal bony connections. And we can see on this x-ray here that's circled that there should be a space there between the bone that's labeled N, the navicular, and the C, the calcaneus. There should be a space, and that area that's circled is an abnormal bony connection. Here's another example of a CT scan showing a coalition beneath the talus and the calcaneus. There should be a space there. And so treatments range from orthotics and immobilization to decrease the pain to surgery to remove the coalition. So here's an example of a before and after where you resect the bony bar and you make a space between the bones to restore the normal anatomy. And usually we'll put a fat or muscle graft between the bones to help prevent regrowth. So that's the end of my talk. And I know it was maybe a lot of topics in a short time, but hopefully there's some little pearls you can glean out of there. And I really appreciate, Dr. Jones, thanks for moderating and thanks for the invitation to talk today. Appreciate it.
You're welcome. So there's going to be one question in the question and answer for you. If you could type the answer in, that would be great.
Yes, I would be happy to do that. Yep.
Thank you very much.